I will introduce Dr. Sarah Sowden and her presentation titled In at the Deep End, Co-Creating a Primary Care Network with Practitioners Serving Communities Living in Areas of Blanket Socioeconomic Deprivation.
Thank you, Mackenzie, and thank you all for having us along today to talk about this project. So, as Mackenzie says, my name is Sarah Sowden. I'm a public health consultant working at the Office for Health Improvement and Disparities in the North East of England, and I'm also a clinical academic at Newcastle University. And the work I'm presenting today is the co-design work around our Deep End network. So it's work on behalf of Dr. Jo Wildman and Dr. Claire Norman, who are the two other people who led this co-design work. So, in at the deep end. I think I should start by telling you all a little bit about what is the Deep End movement and why is it needed. And apologies, some of you may know all about Deep End and some of you won't, so apologies for those that know about it. The great thing is we've had Peter's talk earlier, so a lot of the slides and the graphs I don't need to go into, and we're slightly behind time, so I'll be as quick as I can. But suffice to say, as we know, the inequalities that occur in our health, which are a shocking indictment of the society as we see it today, manifest themselves in many and multiple ways, and this obviously is COVID mortality. And as we can see the gradient in inequalities of deaths involving COVID-19 throughout the pandemic, and this is data that's produced by what was Public Health England and now the Office for Health Improvement and Disparities. And I put this up as the example of the many and multiple different types of data that we could show that our ill health is not equally patterned across our society. So we know that the need for health care and broader care is not equally patterned. And as Peter also said, this is something that Julian Tudor Hart very much advocated throughout his life about what's known as the inverse care law. So that whilst we know that ill health is not patterned equally in our society, we also know that the care, unfortunately, isn't either. So that access to preventative care and primary care is found to be not commensurate to the need and the patterning of ill health across our population. And so the Deep End network movement really goes back to pioneers in Glasgow, who another way of showing this gap and this gradient and the cliff face is to think of a swimming pool analogy. So this was work in 1998, as I say, David Blaine and colleagues in Glasgow. And you can see that the professionals, the higher socioeconomic classes are there quite happily, feet on the bottom of this pool, no problem. Here we go, we're doing okay over here. Whereas very unfortunately, at the other end, for those who are classified as unskilled workers, are literally drowning. So this is where Deep End started. Unfortunately, we know that the inverse care law is alive and kicking, and this is a report by the Health Foundation very recently showing that this is still the case. And so the Deep End network started in Glasgow, and it was about bringing together GPs serving the most deprived communities to share learning and ideas and to address the inverse care law. So the aim of it was to change the way that primary care is delivered and advocate for wider systemic change in healthcare funding. And we mentioned the Carr-Hill formula and how general practice is funded, and the fact that that does not represent the needs as they manifest themselves across our populations. So I'm here today to talk about the Deep End network North East and North Cumbria. Deep End is now an international network. There's Deep End networks springing up all over the place. Our Deep End network in the North East and North Cumbria was established in 2020. It's a partnership with primary care professionals, public health, the NHS, our North East Commissioning Support Service, the ICS, or the Integrated Care Board in our region, funds our network, our Deep End network. And the really great thing is that the ARC, the Applied Research Collaboration, has been around the table from the get-go and the inception of our network, so that we've gone very much a hand-in-glove approach to the development of our network, so that research has informed everything that we've done, and we're informed by research as we continue. So who are the Deep End practices in the North East North Cumbria? We have taken the same formula that was used in in Glasgow. So that is profiling by patients, the postcode of where the patient is rather than the postcode of the practice. The 15% most deprived practices, postcodes in neighbourhoods, and then the deep end practices are in the top 10%, so the top decile of practices serving those very much what we'd call blanket deprivation communities. So in the North East and North Cumbria, we have 36 deep end practices. And in those practices, the practice population is between 56 and 95% of patients in those very much the most disadvantaged population. So that cliff edge, so that's where we're targeting. And indeed, around a quarter of our core 20 in the North East and North Cumbria, a quarter of our core 20 population is served by those 36 general practices. As I said, research has been a feature of our deep end network from the get-go. And when we established our deep end network in 2020, we didn't go saying, this is the network. We said, what is the network? Do we even need one? What are the challenges and what's going on? And we wanted our network to be very much co-designed and co-produced by those people working and living in the deep end. So the bit of research that I'm talking to you about today, the co-design work, had two aims. The first was to generate an in-depth understanding of the challenges of delivering primary care in areas of severe socioeconomic disadvantage, including the experiences of the COVID-19 pandemic. And that was slightly consequential around the timing of our interviews. So it just so happened they were in when the second wave was. So we've got a bit of COVID work in there. The other thing was to co-create with primary care professionals in the deep end network around what that network should be and what are the challenges and how could we overcome those. So we conducted semi-structured interviews with practitioners working in these primary care practices that are identified as deep end. We interviewed 15 participants, 11 GPs, 2 social prescribing link workers and 2 practice nurses. And their deep end careers spanned from 3 months to 31 years. So they'd had a variety of experience of working in the deep end. The interviews, as I say, were conducted October 2020 to March 2021. So the early stages of our second wave of COVID pandemic. And participants were recruited via purposive sampling and snowball sampling, and they were conducted online. We took a thematic content analysis approach to our analysis, and it was undertaken very much through a social determinants of health lens. So what did we find out and what impact did it have? Now, I only have a few minutes, and indeed we're running, I think, slightly behind time. So I've just picked out a few key quotes to exemplify some of the key themes of our research. I put up that graph of COVID-19 mortality purposefully at the start because one of the great things that our research was able to do due to its timing was really provide that lived experience of what it was like to work in deep end practices during the height of the pandemic. And I think this really speaks to giving that voice to the data, as we were talking about earlier in our presentations. The legacy of this, the unemployment, the deprivation, that's just going to get worse for patients. Because as with all of these things, our communities will be the hardest hit going forward. They're not going to bounce back in the ways that other areas may be able to. Turning to the 2 aims that I outlined about our co-design work, there were 4 key themes that emerged through our findings of this phase of the research, and I'm going to just provide a quote to exemplify each. So the first one was the volume of complex patient need that presents in the deep end on a daily basis. We've just talked about cancer in the past presentation for those that were there, but here's a quote to exemplify this. Our patients present later, and that has a lot to do with deprivation, worried about where the next meal is going to come from, not quite so much worried about if there's going to be a little bit of blood in your cough. Mental health came through loud and clear throughout all of the interviews, of this being really at the heart of a lot of the complex patient needs that we're presenting. Here's an example of someone talking about the absolute cocktail of pain meds that patients were on for what they felt was quite shaky indications, and there was a lot of concern about potentially the medicalisation of distress that went on in deep end practices, and also the feeling that, well, aside from a pill, There wasn't a lot that we felt we could give out, and that was something that was really highlighted. Recruitment and retention in the deep end. GP recruitment and retention and primary care workforce more generally is an acute issue, but it is more so in the deep end, and there was a real feeling that this was an eternal struggle to recruit into the deep end, and again going back to Tudor Hart's inverse care law, it really is alive and kicking. And also a really interesting reflection about the perceptions of practitioners working in the deep end from the wider healthcare system. Felt a little bit like the naughty person in the corner with the red line through, always not really doing quite good enough, always missing the targets, always really it's about them and that they're not good enough. And that was really something that came through. There was, however, an optimism and an enthusiasm about the idea of a deep end network. As someone said, a little ray of hope that something might change. Even just providing that label, I'm a deep end practice. Some practitioners said, well, I actually didn't even realise I worked in this area, but having that collective identity to work together, to look at those chronic problems in funding that occur, that advocacy role that's needed was really thought as being important. And as someone says, they really saw it as an opportunity for a change in the narrative and a change in the consensus about how important it is to consider the inverse care law and what we do. So in terms of research impact, we're very fortunate in the North East and North Cumbria that research and practice on the Deep End initiative has gone hand in glove. So that has meant that we are able to directly impact all of our research into practice immediately. So as I said, people valued a supportive community. We have a series of webinars, newsletters and an active community working together across the Deep End. The research has led to the creation of pilot projects addressing the key challenges that were identified, one of which is embedding clinical psychology in primary care. And the other great thing that we've been able to develop through that is very much more an active development around our PPIE and our patient and public engagement work in the Deep End, and getting the views of the patients and the public around what they want from a Deep End is something that we're able to do more through that project. There's also a project on opioid deprescribing and an early career trailblazer fellowship scheme. So just to thank the research team, the research participants, and all of the North East and North Cumbria Deep End network and the applied research collaboration in the North East and North Cumbria for supporting this work.